Hello, I'm a child and adolescent psychiatrist in Australia, and this is a presentation on models of care for children with gender dysphoria. My experience is that it is difficult for child and adolescent psychiatrists and trainees to access information about concerns regarding the affirmation model, as our conferences and work education sessions seem to be largely given by advocates of the affirmation model. The information in these graphs has been obtained through Freedom of Information requests from the gender clinics. The information only goes up to 2019. The large graph on the right shows that across Australia, there has been a large increase between 2014 and 2019 in the number of kids coming under the care of the gender clinics, with Queensland leading the way. However, the true number of children in Australia receiving medical interventions for gender dysphoria using the affirmation model may be much higher, as due to long waiting lists, the gender clinics tend to initiate medical treatments and then refer the young person to a private provider for ongoing prescriptions. The graph on the top left shows the usage of puberty blockers by the clinics, and the graph on the bottom left shows the usage of cross-sex hormones by the gender clinics. The figures across the bottom of the slide are for Queensland. In 2022, the Queensland Children's Gender Service received 616 referrals, started 80 children on puberty blockers, and started 102 children on cross-sex hormones. The clinic had a total number of patients of 922. It has not been possible to obtain information from Australian gender clinics about the proportions of children of each biological sex attending their clinics. This graph reflects data from England, which likely reflects a similar trend to Australia, of an increasing number of adolescent females presenting to gender clinics. This slide is to demonstrate the high level of mental health problems occurring in children presenting to gender clinics. It is information from the Gender Service of the Westmead Hospital in New South Wales regarding their patients between 2013 and 2018. Only 11% of children presenting to their gender service did not have a mental health condition in addition to gender dysphoria. 63% of children had a diagnosis of anxiety, and 62% had a diagnosis of depression. 49% had a history of self-harm, and 16% had ongoing self-harm. Almost 14% had a diagnosis of autism. This is a video of Ellie, age 11. Ellie is a biological female who grew up in England and suffered gender identity disorder, as it was called at that time.
And leave other people alone. I am like this. And my sister is like this. Who made the rules that a girl had to wear a dress and nice pretty shoes and had to have their hair really long, nice all done in plaits? And who made the rules that girls had to play with dolls and boys had to play with footballs? People think I'm a boy because I have my hair like this and I'm dressed like this, and then I just generally look muscular and act like a boy. I was once made to wear a bridesmaid dress there. Can you get that? Look at that face. Terrible. Now, I used to be like this. The hair is just too long. I don't like it.
When she was actually about 2, I can remember trying to get her to wear some clothes that her nana had bought her, some very pretty little dresses, and Eleanor actually really making a big fuss about not wanting to wear them.
I don't like wearing a dress because I just get in the way and it's just too open for me. I like something that will stay there and something I know isn't going to come off.
This is Ellie on the right as an adult with her female partner. Ellie attended the Tavistock's Gender Identity Development Service prior to when the clinic introduced the use of puberty blockers and cross-sex hormones for adolescents. This is audio of Ellie speaking about her experiences of recovering from gender dysphoria through talking therapy.
So I'm interested if you remember the content of those discussions. And obviously you sit here before us not having medicalized, as far as I can presume. So what happened in those sessions, and what was the, quote, treatment recommended to your family?
It was just talking. There was just a lot of talking. So, and the talking was, what do you feel about yourself? And I know I used to say things like, my hands are so big. Like, I've got bigger hands than any of the other girls. I've got bigger hands than the boys in my class. I've got the biggest hands. And look at my legs, and I'm really muscly and I'm really strong. And all of these things, that's what we talk about. Like, how do I feel about my body in comparison to other people? And that, and then gender roles, and lots about gender roles, which was, and what do I like to do? Like, what do I like to do? And what are my activities? And then I really think, because it's not clear in my head, and and I'd love to read the notes. If the notes are anywhere, I'd love to read the notes, but where they are, I do not know. Is that he, at the time, would have said, well, do you think those roles are fixed, or do you think anyone owns those roles? And then question me, being like, oh, well, maybe nobody does own those roles, all those activities, all those things, but other people are telling me that. So through the course of the time of my therapy, that was the ultimate conclusion when I was discharged, which was, no, I don't want to be a boy. Like, I don't need to be a boy. What I need is to be allowed to do what the boys are doing.
The prevalence of gender dysphoria has changed over recent decades. Historically, gender identity disorder was rare, about 1 in 10,000 boys and 1 in 27,000 girls. However, studies of young people in the Western world now estimate that gender dysphoria is much more common, up to 1 in 100 or 1 in 25 children, and even higher in some areas. Historically, it was mainly male children presenting with gender dysphoria, but more recently it is predominantly adolescent females. What is not controversial is that the vast majority of children with gender dysphoria become comfortable with their own body by adulthood. To show that this isn't a controversial statement, I have used multiple sources of information, including from advocates of the affirmation model. There are 11 studies, which I will show you in subsequent slides, which have tracked children presenting to gender clinics suffering distress regarding their gender and a cross-sex identification, from childhood through to adulthood, and have found high rates of resolution of gender dysphoria. The DSM-5 states, rates of persistence of gender dysphoria from childhood into adolescence or adulthood vary. In natal males, persistence has ranged from 2.2% to 30%. In natal females, persistence has ranged from 12% to 50%. The Dutch researchers who developed the affirmation model, and will be discussed in detail in coming slides, have said, across all studies, the persistence rate of gender dysphoria has been approximately 16%. Even the Queensland Children's Gender Service, in their information for parents, says the majority of children with gender non-conforming behaviour will identify with their assigned gender at birth around or after puberty. Michelle Telfer is a paediatrician who has been working in the Royal Children's Hospital in Melbourne Gender Service since 2012 and has been a key proponent of the affirmation model in Australia, including successful bids through the Family Court to allow children access to puberty blockers and hormones without having to go through the court. So this is Michelle Telfer speaking about the high proportion of children with gender dysphoria that become comfortable with their own body over time.
And if we look at gender variant children, essentially they may progress, and only a small percentage, we suspect only 15 to 20% of gender variant children persist with their transgender identification post onset of puberty. The remaining 80% progress to identifying as non-transgender or, in other words, cisgender, and can either identify as heterosexual or as lesbian, gay or bisexual. The non-gender variant children, as you would be aware, again, can either identify post-puberty as either cisgender, so non-transgender, lesbian, gay, bisexual, or as heterosexual adolescents.
So here are the 11 studies that I previously mentioned that show the high rate of resolution of gender dysphoria in children as they go through adolescence into adulthood. The studies are shown on this slide and the next one. The early studies look at the outcomes for children presenting to gender clinics. Presenting to a gender clinic would have been a marker of severity of symptoms in the 1970s and 80s. The later, larger studies use the DSM criteria to diagnose gender identity disorder. Psychologist James Cantor compiled this table and concluded, there have been 3 large-scale follow-up studies and a handful of smaller ones. Despite the differences in country, culture, decade, and follow-up length and method, all the studies have come to a remarkably similar conclusion. Only very few trans kids still want to transition by the time they are adults. Instead, they generally turn out to be regular, gay, or lesbian. The exact number varies by study, but roughly 60 to 90% of trans kids turn out no longer to be trans by adulthood. Proponents of the affirmation model will try to dismiss the findings of all of these studies by saying that they are not relevant due to changes in the DSM diagnostic criteria. The condition was called gender identity disorder in children in DSM-4-TR, published in the year 2000, and changed to being called gender dysphoria in DSM-5, published in 2013. However, as you can see from this slide, the diagnostic criteria for these diagnoses is almost identical. The earlier diagnosis, gender identity disorder, says that the condition needs to be strong and persistent, whereas the later diagnosis just specifies a duration of 6 months. Both sets of criteria contain requirements for cross-sex identification and a strong desire to be the opposite sex. They both specify the child should show a preference for cross-sex clothing, a desire to participate in games and pastimes of the other sex, and prefer playmates of the opposite sex. Gender identity disorder specifies that the child must have hatred of their own body and an aversion or rejection of stereotypical male play in male children, or body hatred and an aversion to feminine clothing in female children. However, a child with gender dysphoria is not required to have body hatred if they meet 6 other of the criteria listed. A gender dysphoria diagnosis allows for a disorder of sex development, whereas gender identity disorder did not. So the change in the DSM name and slight change in diagnostic criteria for these conditions does not impact on the validity of these studies. However, the cohort of children included in these studies does reflect the cohort of children presenting to gender clinics before about 2017, and they were mostly male and had long-term gender dysphoria from childhood. As discussed earlier, this differs from the children presenting to gender clinics today, who are predominantly adolescent females with very little objectively observed history of cross-sex identification and a high level of mental health and developmental comorbidity. So what we do know is that the affirmation model stops this natural process of children recovering from gender dysphoria and becoming comfortable in their own body. This American study, published in 2022 by Christina Olson and her team, examined the 5-year gender identity development trajectory of 317 transgender identified children who underwent early social transition with changes to their clothing, name and pronoun. The children were on average 6 to 7 years old at the time of the social transition. 5 years later, at the age of 11 to 12, almost all, 97.5%, continued to identify as transgender, including a small subset, 3.5%, developing a non-binary identification. At the end of the study, 60% of children had started taking puberty blockers. So compared to the high rates of children recovering from gender dysphoria prior to the affirmation model, once the affirmation model is used, children do not recover from their gender dysphoria. A 2013 study by the Dutch found that social transition caused children to be 5 times more likely to persist in their gender identity disorder. The study published by the Tavistock Gender Identity Development Service in 2021 of 44 children aged 12 to 15 with persistent gender dysphoria found that only 1 of 44 children didn't progress from puberty blockers to cross-sex hormones. So the concern is that gender-affirming care prevents the natural process of children becoming comfortable in their own body and causes gender dysphoria to persist. When this concern is raised, advocates for the affirmation model will say, if you look at the studies, those children who are still experiencing gender dysphoria at the start of puberty are almost all likely to persist. However, if you take the time to look at the references used by the advocates to support this statement, the references don't actually support this statement at all. I want to go through the 2 studies that are cited by proponents of the affirmation model to support the false statement that children with gender dysphoria at the start of puberty are likely to persist in their gender dysphoria. Both of these studies, referenced to make this false claim, come from the Dutch clinic in Amsterdam. The Dutch clinic is unique in that virtually all medical care for gender goes through the one clinic, which is the VU University Medical Centre. They do not have private specialists or general practitioners providing medical care for gender concerns. This is the most confusing part of the presentation because I'm going to go through 2 studies to show you that those studies don't show you what people say they do. The first is a study that was published in 2011. The subjects of the study were children under the age of 12 who were seen at the Dutch clinic between the year 2000 and 2007 and received a diagnosis of gender identity disorder. When the study was conducted in 2010, the child had to be aged between 14 and 18. The researchers noted that 53 adolescents met the criteria for this study. The researchers conducted qualitative interviews with 25 of these 53 children and did not specify how they selected these children out of the group of 53 who were eligible. The children interviewed included 14 who had returned to the clinic between the age of 12 and 14 to receive puberty blockers and cross-sex hormones. These adolescents were called persisters. At the time of the study, this group was, on average, age 16. The other group was of 11 children who had not returned to the clinic to receive puberty blockers and hormones. These adolescents were called desisters. They had an average age of 15. So this study does not attempt to determine at what age gender dysphoria eases. The reason that this study does not provide any evidence for this false statement that children that reach Tanner's stage 2, aged about 10 to 12 with gender dysphoria, will persist in their gender dysphoria, is that the persisters in this study were not given time to desist. They were given puberty blockers from the age of 12 onwards. Because the desister group had a mean age of 15, this study selected for a group of people who had improved in their gender dysphoria before the age of 15. However, the study did provide some useful qualitative information about how the young desisters did desist. In desisters, the gender discomfort gradually decreased over the courses of grades 7 and 8, aged 10 to 13. Both boys and girls indicated that their changing interests and friendships and the physical changes during puberty made the gender discomfort diminish and eventually disappear. The desisters also reported that their first experience of falling in love and awareness of sexual attraction were factors that resulted in the disappearance of their gender dysphoria. As for their preferences for gender-related activities and friendships, the desisters indicated that their gender atypical interests did not necessarily evaporate, but that they just became more receptive to gender-typical interests. As a result, they developed more affiliation with children of their own gender and more often engaged in same-gender friendships. I think that this information tells us that it is the whole course of puberty which can assist children to be comfortable with their own body. It tells us that it is the formation of strong friendships, the sexual awakening, falling in love and experiences of physical intimacy that can heal gender dysphoria. These experiences are absolutely not limited to children in Tanner's stage 2, that is age 10 to 12. These experiences are actually much more likely to occur in mid and late adolescence, especially in today's youth, who tend to develop socially later than previous generations. This is the second study which is used by people to falsely claim that children with gender dysphoria in Tanner's stage 2, that is age 10 to 12, are likely to persist in their gender dysphoria. The subjects are the first 150 children who attended the Dutch clinic and were diagnosed with gender dysphoria between the ages of 5 and 12. 2/3 were male. At the time of the study, the subjects were aged between 19 and 38. 40 children out of the 150 persisted with their gender dysphoria, which is a percentage of 26.7%. The mean age of children returning to the clinic after their assessment, which first occurred before the age of 12, was aged 13.14 years. The researchers found that 75% of children returned to receive treatment before the age of 14, and 25% returned between the age of 14 and 18. 5 people returned in adulthood. So once again, this study does not provide evidence regarding the age at which gender dysphoria tends to persist or heal. This study is not a study of the age at which desistance tends to occur. The Dutch researchers knew in the early 2010s that social transition places pressure on children and causes gender dysphoria to persist. They wrote, "Because most gender dysphoric children will not remain gender dysphoric through adolescence, we recommend that young children not yet make a complete social transition," meaning different clothing, a different given name, referring to a boy as her instead of him, before the very early stages of puberty. In making this recommendation, we aim to prevent youths with non-persisting gender dysphoria from having to make a complete change back to the role of their natal gender. In a qualitative follow-up study, several youths indicated how difficult it was for them to realise that they no longer wanted to live in the role of the other gender, and to make this clear to the people around them. These children never even officially transitioned, but just were considered by everyone around them as belonging to the other, non-natal gender. One may wonder how difficult it would be for children living already for years in an environment where no one except for family is aware of the child's natal sex to make a change back. There is no way of knowing which children presenting with gender dysphoria will continue to present with gender dysphoria into adulthood. This is a video of Marcy Bowers, who is an American surgeon who specialises in vaginoplasty and has performed thousands of vaginoplasties. Marcy is a trans person and is the president of WPATH, which is the World Professional Association for Transgender Health.
The second was an observation that I had, that every single child or adolescent who was truly blocked at Tanner stage 2 has never experienced orgasm. I mean, it's really about zero. These are just assigned male at birth, so trans feminine, and it's because they never in their lives are exposed to testosterone. That doesn't change. So blockers prevent the rise of testosterone, and they don't really go on testosterone at or around surgery or into adulthood. And so we don't know. They're going to have this sensation. There's no question about that. But are they going to be able to achieve sexual satisfaction? It's important in relationships. And I know that from my work with female genital mutilation survivors, that the lack of being able to be intimate with a partner is very important. And so this is what really raised the red flag for me, is to say, look, we need to have our eyes open about it. I think it's been beneficial talking about it. I know Joe and many others have reported to me, they've changed their approach a little bit in their informed consent models, and that we're talking about masturbation now. We're talking about, okay, that's an area of the body that's got very dysphoric for you, but you know what? It's all a penis is just a large clitoris. I mean, it's all the same material. It really is. So use it for the pleasurable purposes, partially that it was intended, and we'll see what happens. But these are to be answered questions. So, can we avoid puberty and get good adult results? And secondly, how do we assure someone that they're going to be able to be sexually responsive? Do we remove the blockers during the course of their adolescence and let a little bit of puberty come back? Do we delay it a little bit, maybe into Tanner's 3 or 4, maybe before they have their first orgasms? Maybe.
The health consequences of the affirmation model for those given puberty blockers in Tanner's stage 2 and then cross-sex hormones is that they will be infertile. Post-pubertal males who take estrogen for 12 months will be infertile. They also have a higher risk of breast cancer and strokes from venous blood clots. Post-pubertal females taking testosterone have a higher rate of cardiovascular morbidity and a reduction in their fertility. They experience gynecological problems from testosterone, which can sometimes require hysterectomy. Double mastectomy surgery carries all the risks we know about surgery, as well as changes in chest sensation and phantom pain. This is audio of 2 people who transitioned as adults talking about their experiences of this. The person on the left is Buck Angel, who is a natal female, and the person on the right is Corinna Cohen, who is a natal male.
You felt like this was more important, but I guess my question also is, did people ask you, or did they tell you, like, you're going to lose your orgasm, you're not going to have sex? Did they say these things to you?
You know what the community is like, Buck, is everybody talks up their treatments and their surgeries like it's the top of the line Cadillac version. No matter who they go to, even if they come away with permanent injury, they will still talk about how awesome it is.
You're right.
I want to bring up something since we're on this topic.
Yeah.
In WPATH SOC8 that just came out, and these are the treatment recommendations from the World Professional Association for Transgender Health. In the chapter 6, which is on adolescent care, if you go and you download that document and you search for orgasm, the first occurrence of the word orgasm is in the chapter on adolescence, where they're saying that they're making reference that 87% of trans women report that they can orgasm, and therefore altering the genitals of an adolescent boy is justifiable on that basis. And I've been having conversations with other post-op transsexuals about what that means, what orgasm means. Before surgery, orgasm, it was disturbing in some ways. This is called dysphoria, when your body is behaving normally, but you have a bad reaction to it behaving normally. Orgasm felt powerful and strong and vivid, and good is not the right word, because it also came with a lot of anxiety and feelings of wrongness. But it was like a powerful thing. So can I orgasm now? I can it is a very weak puff of it's like when you can't quite sneeze and then you can sneeze, or you can't quite yawn. Yeah. When you know that you want to yawn, I'm sorry for everybody listening if that made you yawn. When you're trying to yawn and you can't, and then you take a deep breath and you can get that yawn out, that's about my experience of orgasm. And other post-op transsexuals that I've spoken with have said, oh yes, what you're describing, that sounds like what I'm experiencing too. If we're telling kids 87% of the boys who have sex reassignment surgery have vaginoplasty, can orgasm, it is not going to be anything like having that orgasm before surgery. And what I would say is that post-op, I can orgasm much in the same way that somebody who's had a foot amputation can.
And even, I'll tell you, to be honest, I even thought I was okay with puberty blockers early on, because I was like, wow, you get to transition as a kid. That's amazing. And then I thought it was an actual amazing thing until it literally wasn't an amazing thing. And, I started doing more of my research. I started listening more. The community started to grow to this insane space it is. Then I pulled back because I didn't see what changed my mind is I don't see the desire to create a space for these people with the intention of love and compassion. It feels to me more like a rush. And it feels to me like there's some agenda attached to it. Like they don't care about these people. How many people can we trans before they catch on? That's what I feel. And I don't know if I'm wrong or right, but it's what I feel. And so again, I tell you, I'm a person who really feels like I have integrity on some level. And if I didn't sort of look at all sides and speak up about it, then I'm not being a good trans, elder or a good person. So I used to think that about that, but now I don't, because I don't think they have the same objective that they used to. And I think there's too many. There's no way there's this many young people trans. No way. No.
I used to be something kind of like not as much as you, obviously, so I want you to talk about this, but I used to be a little bit of like a trans ambassador in that I was the first trans people or trans person that people got to know.
Yeah.
And there was always this idea that people might not like trans people in the abstract, but if you got to know somebody who's trans, you would see that they're a normal person and you'd start to relate to them and like them. I'm thinking about part of the evolution of my reconsideration of starting transition early. And I think it's because, partly at least, that as I know more and more detransitioners, and I learn that they've been failed by the clinicians in not having enough precaution or precautionary guidance before medicalization, that knowing those detransitioners is part what gets me to reconsider.
That's right.
And I wonder if this is something like what we experienced as trans, if the world starts to get to know more detransitioners, if they will change their viewpoint on adolescent transition.
Yeah.
This is a video of Michelle Telfer, who we met earlier in this PowerPoint. You will recall that she is a paediatrician who has been working in the Royal Children's Hospital in Melbourne Gender Service since 2012 and has been a key proponent of the affirmation model in Australia. This is audio of Michelle speaking about their clinical approach to patients attending the Melbourne Royal Children's Hospital Gender Service.
What's really interesting though, Coleman, is that over time what we're seeing is further individualisation of hormone treatments. So, and this has really come from demand from the community and listening to what the trans community are telling us in terms of what they need. And some people are opting to have hormone treatment for a certain period of time and then to deliberately and in a planned way stop taking it. So I can give you an example of this. So someone who, for example, is assigned female at birth and has a non-binary gender identity, they might come to us and say, I have a non-binary gender identity and I want to masculinize to a certain extent, but I don't want to look sort of in a way that I'm a man. I want to look not exclusively male or female. I want my body to reflect my non-binary gender identity. And we have the same process. You know, we meet with them and with their family and we talk through all of the short-term, medium-term, long-term kind of concerns and plans and dreams and wishes. And we talk about all the risks and benefits of the different treatments. And some of these young people are opting to have testosterone for a certain amount of time. often about 6 months, where they want to have a deeper voice, and they might want also to have some masculinization of their face. But for them, they get to a point of masculinization where they feel that's right for them, and then they stop taking testosterone.
I want to take a moment to remind people of a well-known principle of psychodynamic psychotherapy, which is that of collusion. This is where a clinician, consciously or unconsciously, participates with the patient to avoid an issue or feeling that needs to be addressed. For example, this could be colluding with a patient to avoid exploring the underlying reasons for a feeling of disgust towards their own body. Another principle to remember is that certainty can be a defense against uncertainty. For example, adolescents can present a wall of certainty that they are trans and that transition is the solution to all of their problems to protect themselves from their underlying anxiety and uncertainty about aspects of their life. So now I will talk a little bit about how the affirmation model began. The use of gonadotrophin-releasing hormone agonists was first proposed to suppress puberty in children with gender dysphoria in the mid-1990s. This was because researchers were noticing that transition in adulthood failed to resolve mental health problems. There was sharing of information between 3 gender clinics operating at that time: the Dutch, the Boston Children's Hospital under Norman Spack, and the Tavistock's Gender Identity Development Service in the UK. These groups worked together on the Harry Benjamin International Gender Dysphoria Association Standards of Care for Gender Identity Disorders, 6th version, which was published in 2001. The Harry Benjamin Association changed its name to WPATH in 2007. The Harry Benjamin Standards of Care noted, before any physical intervention is considered, extensive exploration of psychological, family, and social issues should be undertaken. Adolescents' gender identity development can rapidly and unexpectedly evolve. Identity beliefs in adolescence may become firmly held and strongly expressed, giving a false impression of irreversibility. More fluidity may return at a later stage. For these reasons, irreversible physical interventions should be delayed as long as is clinically appropriate. Pressure for physical interventions because of an adolescent's level of distress can be great, and in such circumstances, a referral to a child and adolescent multidisciplinary specialty service should be considered. However, they gave the green light to puberty-delaying hormones as soon as pubertal changes had begun, on the basis that A, to gain time to further explore the gender identity and other issues in psychotherapy. This is because back in 2001, they did not realise that puberty blockers freeze the child into their gender dysphoria. They didn't realise that puberty blockers prevent a child from healing in their gender dysphoria through the course of important physical changes and social experiences occurring during adolescence. And the second reason for puberty blockers was that they were also focused on a cosmetic result from avoiding puberty, and this likely reflects that only a small number of children presented with gender dysphoria back then, and it was predominantly male children. The standards of care note that, to be eligible for puberty blockers, the child should have demonstrated an intense pattern of gender dysphoria throughout childhood, which had increased at the onset of puberty, and the family was supportive. What is surprising about the widespread adoption of the affirmation model across the Western world is that it is based on a very poor level of research evidence. The use of puberty blockers in children was rare until the Dutch researchers published data regarding the first 70 adolescents referred to the Amsterdam clinic between the years of 2000 and to 2008. The 2 studies published in 2011 and 2014 are about this same cohort of patients. These studies have been used as the basis of the Endocrine Society's 2017 Clinical Practice Guideline and the WPATH Standards of Care. So let's look at the first of these 2 papers, which was published in 2011, The subjects of the study were children who received puberty blockers between the years 2000 and 2008 after being diagnosed with gender identity disorder, which was persistent since childhood. They had to be living in a supportive environment and to have had no serious comorbid psychiatric disorders. So the cohort of this study is quite different to the cohort of children presenting to gender clinics these days, who have a high level of psychiatric comorbidity and family dysfunction. The subjects were given puberty blockers in Tanner's stage 2 or 3. They had undergone a comprehensive psychological evaluation with many sessions over a long period of time. The subjects were assessed using the following measures: the Child Behaviour Checklist, Youth Self-Report, Beck Depression Inventory, Spielberger Trait Anxiety and Anger Scales, the Clinician-Rated Children's Global Assessment Scale, the Utrecht Gender Dysphoria Scale, and the Body Image Scale. These measures were given to subjects just before starting puberty blockers and again just before starting cross-sex hormones. The time between these two assessments was, on average, almost 2 years. So between the years 2000 and 2008, there were 111 adolescents who met the criteria to enter the study and started puberty blockers. However, participants in this study were the first 70 adolescents who started cross-sex hormones. There was no explanation given as to why the study cohort dropped from 111 down to 70, which is a loss of 37% of subjects in just under 2 years. Amongst the 70, they were almost half male and half female, and 88% reported being same natal sex attracted. The average age for starting puberty blockers was very late compared to today's standards, just under age 15 for males and just over age 15 for females. The subjects received extensive or other social support and were regularly seen by the clinic psychologists and psychiatrists. The study found that the adolescents about to start cross-sex hormones had slightly fewer behavioural and emotional problems and reported fewer depressive symptoms. Feelings of anxiety and anger had not changed. General functioning somewhat improved. So now we should look at the second Dutch study that underpins the affirmation model. It is the same cohort of subjects. However, in this study, the number of subjects has dropped to 55. The study is of 55 young transgender adults, 22 natal females and 33 natal males, who had undergone gonadectomy at least 1 year earlier. The mean age of the subjects was 20. Regarding the 15 that were not included in this study, the researchers explain that 6 of these were not yet 1 year post their gonadectomy, but they do not give an explanation as to why they stopped the study early and didn't wait to include these people. 2 subjects are listed as refusal and 2 failed to return the questionnaires. 1 is a dropout. The researchers didn't explain why, after many years of attending the clinic, these young people weren't willing to engage. 3 subjects were not medically eligible for surgery due to obesity and diabetes. 1 natal male died due to the complications of vaginoplasty. This is because when males in Tanner's stage 2 are given puberty blockers and then estrogen, their penis remains small and there isn't enough skin to make a vaginal tube, and so the surgeon has to use part of the colon, which is a much more dangerous surgical procedure. Only 40 subjects out of the 55 had complete data. A large number of measures were used. On the measures, the researchers found that, compared to prior to pubertal suppression, the natal female subjects had reduced anger, anxiety and externalizing behaviours. Natal males showed the same or slightly more symptomatology on these scales. The researchers reported that the gender dysphoria had resolved. Now I want to outline the main criticisms of these studies. The first is that there was no control group. We don't know how the subjects might have naturally changed in their gender dysphoria or other psychological measures as they aged. The average age of starting puberty blockers was 15, rather than 12 as outlined by the protocol. This makes the outcomes less applicable to current approaches of starting puberty blockers in Tanner Stage 2, which is age 10 to 12. The children studied are different to the current population of children presenting to gender clinics. It was a highly selected group of children with long-standing childhood gender dysphoria, no mental health comorbidity and strong family support. The study has a very short follow-up time frame. The findings are only from 12 to 18 months following gonadectomy. The intervention included regular psychologist and psychiatrist appointments and was not just medication and surgical interventions, which could have led to improvements in psychological functioning. There was a high level of bias. Only the most successful cases at each stage were included in the reported results. From the 111 of the first study dropped to 70 subjects without explanation. To participate in the first study, the participant had to be ready to start cross-sex hormones. In the 2014 study, the sample is skewed towards those people willing to undergo surgery. One of the main findings of the studies was that the gender dysphoria resolved. However, this outcome was achieved because the researchers swapped which version of the Utrecht Gender Dysphoria Scale was given to the subject between the start and the end of the study. According to the 2014 Dutch study, gender dysphoria scores on the Utrecht Gender Dysphoria Scale plummeted from a near maximum of score of 54, where the maximum 60 at baseline, to the near minimum score of 16, where the minimum on the scale is 12, after the final surgery. The switching of which Utrecht Gender Dysphoria Scale was given to patients entirely invalidated the study's main finding. Rather than a true resolution of gender dysphoria, the drop in gender dysphoria scores was the result of switching the scale from female to male versions and vice versa before and after treatment. So you can see, if the subject was a natal female, at the start of the study they were asked questions such as, I prefer to behave like a boy, which they would strongly endorse. Every time someone treats me like a girl, I feel hurt, which they would strongly endorse. I love to live as a girl, which they would strongly disagree with, and so on. Then once they had undergone pubertal suppression, testosterone treatment and a double mastectomy and removal of their ovaries, they would be given the male version of the questionnaire, which includes questions such as, my life would be meaningless if I would have to live as a boy, which they would strongly disagree with. Every time someone treats me like a boy, I feel hurt, which they again would strongly disagree with, and so on. The Dutch protocol was considered an innovative practice, which is a rapid advance in the medical field, but is capable of hurting individuals and societies by promoting a non-beneficial or harmful intervention. There is an ethical requirement that, as soon as viability of the new intervention is demonstrated, the intervention must move into a high-quality research setting capable of demonstrating that the benefit outweighs the risk. This never happened, and gender medicine became a runaway clinical intervention. Dutch studies failed to show that the interventions resulted in meaningful psychological improvements significant enough to justify the adverse effects of the treatment, including permanent infertility. Proponents of the affirmation model will say that a lot of interventions in child and adolescent psychiatry are not underpinned by strong evidence due to the lack of research trials conducted on children. However, in my opinion, because the affirmation model poses such a high risk of harm, there needs to be high-quality research evidence demonstrating substantial benefit to justify these interventions. So let's meet some detransitioners, as Corinna Cohen suggested we do earlier. This is a natal male who underwent puberty suppression and estrogen treatment in adolescence.
I wanted to give myself time to really explore my feelings and detransition before I shared them with you. But if you want to see the truth, this is the truth. I'm an almost 30-year-old man. This is what I look like. This is what I sound like as an almost 30-year-old man. This is what happens when you let people transition in adolescence before they've had a chance to grow up. Before they had a chance to even learn who they were. Not just but pressure people to transition at these ages. Young, vulnerable people who are already so suggestible. And I feel like everyone is ignoring the pain because they are afraid that it threatens their choices and their narrative. If you want to transition in your 20s, you've had a chance to be a man or a woman, and this is what you want to do, okay, that's one thing. But the active pressuring of people to transition so they can preserve their femininity, which is what happened with me, I was told that if I allowed myself to age, that I would become masculine and that it would never be possible and that I would do it anyway, and that I would be a more masculine transgender person like them.
This is Kira Bell, who is an English woman who attended the Gender Identity Development Service through the Tavistock in the UK and was prescribed puberty blockers, testosterone, and had a double mastectomy. She's famous because in 2020 she was a claimant against the Tavistock and Portman Foundation Trust in a judicial review case, which is a system which allows people in Britain to bring action against a public body they deem to have violated its legal duties. 3 High Court judges in a unanimous verdict found that children under the age of 16, considering gender reassignment, are unlikely to be mature enough to give informed consent to be prescribed puberty-blocking drugs. In 2021, the Court of Appeal found that it was inappropriate for the High Court to issue that guidance because it is an established legal principle that it was for clinicians rather than the court to decide on competence to consent.
Take me back to when you were a teenager then. How did you feel about yourself and what made you decide then that you wanted to transition?
Yeah, I mean, during my teens, it was, I was really struggling, mental health issues, struggling with my sexuality, and just struggling in general with not fitting into the stereotype of, the stereotype that girls are supposed to fit in, society says. And so, yeah, all of this just kind of manifested into gender dysphoria and, was later seen at the Tavistock.
And did you know what gender dysphoria was? Did you feel like you were in the wrong body? Is that how you felt?
Yeah. I mean, I didn't know the term for it before I kind of looked up online. But yeah, once I did, it just kind of made sense. I was like, yeah, that's me, because it explained everything that I was already feeling. I checked every box.
This slide is about the Gender Identity Development Service study, which is the only study that attempted to replicate the Dutch studies with more than a handful of cases. Subjects were recruited between 2011 and 2014. The results of this study were only published in 2021 after pressure from Freedom of Information requests, and the allegation is that the results of this study were buried because the clinic didn't like its findings. Puberty blockers were extended to children as young as 12 at attending GIDS in April 2014, despite the results of this study. This is an uncontrolled, so no control group, prospective, which means going forward, observational study of puberty blockers in 44 children aged between 12 and 15 years who had persistent and severe gender dysphoria with an intense pattern of cross-gendered behaviours and cross-gender identity throughout childhood, which they defined as for longer than 5 years. Children with serious psychiatric conditions were excluded. The measures used were the Child Behaviour Checklist, Youth Self-Report, and CBCL and Youth Self-Report self-harm indices. 44 patients had data at 12 months follow-up, 24 patients at 24 months and 14 patients at 36 months. Now these were not dropouts. These children left the study when they went on to cross-sex hormones. The risks that were discussed with the young people entering the study include symptoms resulting from the withdrawal of sex steroids such as headaches and hot flushes, fatigue, loss of libido, low mood, effects on bone density, and continuation of gender dysphoria, showing that even as early as 2011, the GIDS service at the Tavistock understood that puberty blockers led to the continuation of gender dysphoria, preventing the natural healing of gender dysphoria that occurs across adolescence. At the end of this study, only one child ceased puberty blockers, and 43, which was 98%, elected to go on to cross-sex hormones. The conclusion of the study was that there were no changes in psychological function made by the puberty blockers. This is a parent information handout from the Queensland Children's Gender Service, which you will find on their website. Notice that the pictures show small children. In the top red circle it says, studies show that strong parental support of their gender-diverse child leads to a 95% reduction in suicide attempts comparative to parents who are unsupportive or only somewhat supportive. Some parents may experience struggles in affirming their child. The reference for these statements is shown in the bottom right red circle. It is the TransPulse 2012 survey. So I want to talk about this TransPulse study, which is being used to suggest that parents need to affirm their child in order to reduce their child's suicide attempt rate by 95%. The TransPulse study is not a peer-reviewed publication. It is a self-published document posted on the internet. Participants were recruited through respondent-driven sampling over a 12-month period in 2009 to 2010, and it included 123 trans youth aged between 16 to 24, 84 of whom had socially transitioned and provided information on how supportive their parents were of their gender identity or expression. So this analysis is based on the self-report information obtained from these 84 youth. The recruitment for this survey took place via 16 well-connected trans people in Toronto who were known to a trans community support organisation. These people then recruited their friends using a financial incentive. The study likely did not include children who were happy in their home and had not required the support of advocacy groups. The study found consideration of suicide was common and reported by 35% of youth whose parents were strongly supportive and 60% of those whose parents were not strongly supportive. Particularly alarming is that among this latter 60%, nearly all, 57%, had actually attempted suicide in the past year. In contrast, only 4% of those with strongly supportive parents attempted suicide. However, this was a cross-sectional survey, so it was not able to determine causal relationships. It cannot exclude reverse causality, such as a person's pre-existing mental health conditions and suicidality, being the cause of their parents not supporting transition rather than a consequence. The assessment of the parents' level of support comes from a single question in an 87-page survey, which was, in general, how supportive of your gender identity or expression are the following people, taking the item which specified parents. This survey doesn't consider any confounders such as homelessness, bullying, poverty, culture, education level, or other disadvantage being drivers of suicidality and also possibly correlated with perceived unsupportive parents. For example, the study also found, while not statistically significant, for those with parents strongly supportive of their gender identity and expression, 92% reported having adequate food compared to 82% of those with parents not strongly supportive. We are not told the ages of the participants of the survey, only that they are between the ages of 16 and 24. They may well have been mostly in their 20s because the survey was illustrated with cartoons regarding sex reassignment surgery, suggesting it was for an adult audience. Also not reported is the respondents' natal sex or age from which they identified as transgender, which may link to their perception of their parents' level of support. There's no information given about any comorbid mental health diagnoses. There's odd findings within the survey which are ignored, such as 45% of those with unsupportive parents were satisfied with life versus 20% or less of those with somewhat supportive parents. 70% of those with somewhat supportive parents had made a past year suicide attempt versus 30% of those with unsupportive parents. Findings from this survey are not reliable, and the population in this study is not generalisable to a present-day cohort who are predominantly adolescent females with onset of gender dysphoria in adolescence, let alone to primary school children as suggested in the hospital information sheet. You will notice in media reports and in interviews with advocates of the affirmation model, when they are discussing puberty blockers and cross-sex hormones in children, they will report a 1% regret rate. This claim is made by referencing two studies, neither of which is applicable to children and adolescents taking puberty blockers and cross-sex hormones. The first study is from the Dutch clinic and was published in 2018. The researchers looked at the medical records of all the people seen at their clinic between 1972 and 2015. This was a retrospective medical record review. They looked at the medical records of 6,793 subjects. Roughly 2/3 were male. In order to be considered someone who had regretted their transition in this study, the subject had to have undergone a gonadectomy and then returned to taking the hormones of their natal gender. They had to have told the clinic about their feelings of regret, and those feelings had to have been documented in their clinical file. Most of the subjects in this study had transitioned as mature adults. The group of adolescents in this study is small, and they had a shorter duration of follow-up because the number of adolescents presenting to the clinic with gender dysphoria only started to increase in 2015, shortly before the study finished. And we know that the adolescents undergoing the affirmation model through the clinic at that time were a highly selected group with early childhood onset gender dysphoria, no psychiatric comorbidity, and supportive families. 36% of eligible people had dropped out of attending the clinic and so did not have data to be included in this study. The study identified 14 people out of 6,793 people who reached that very high bar to be classified as a regretter, and their regret was expressed on average 10 years after their transition. We know that regret is a complex emotion, and this study has an incredibly high bar to reach to be considered a regretter. Using this criteria, Kira Bell would not be considered a regretter as she did not undergo gonadectomy. Corinna Cohen would not be considered a regretter because Corinna has not decided to take testosterone. The other study that is used to claim a 1% regret rate for adolescents treated with the affirmation model is a study published in 2021 by Valeria Bustos and her team. The researchers combined the results of 27 studies to form a group of 7,928 subjects who had undergone any type of gender affirmation surgery. The subjects were 2/3 male. Almost all studies were of poor and fair quality using the National Institute of Health Quality Assessment tool. The studies had high rates of losses to follow-up and did not use valid assessment measures. Follow-up times were variable, with some studies having a very short follow-up. The subjects were mostly adults. Only 5 studies, representing just 3%, or 174 of the participants, received higher quality ratings. However, even these had losses to follow-up rates ranging from 28 to more than 40%, including loss through death from complications of surgery or suicide. The authors overlooked numerous relevant studies, including one of the best known, raising questions about the adequacy of their search strategy. One study was inappropriately included in this study as it only investigated regret regarding choice of surgical procedure, not of surgery itself. There were significant data extraction errors leading to erroneous conclusions. For instance, the sample in the largest included study was incorrectly inflated from 2,627 to 4,863, likely due to a miscalculation from a table. The cohort presenting with gender dysphoria today is substantially different from the cohort presenting during the research periods of the included studies, which were from the late 80s and 90s, the pooled prevalence of regret after gender-affirming surgery was found to be 1%. This slide presents a study which looks at desistance rates for people on cross-sex hormones. It is an American study published in 2022 which looked at medical and pharmacy records between 2009 to 2018 from the US military healthcare system. They looked at the children and spouses of active, retired or deceased military members who identified as trans. To be eligible for the study, the subject had to have had at least 2 medical appointments on different days where a transgender-related diagnosis was given, and they had to have filled a prescription for a cross-sex hormone within 90 days of the appointment where they received the diagnosis. The subject had to have filled at least 2 prescriptions for cross-sex hormones, so the study looked for people who then had a greater than 90-day break from cross-sex hormones, according to their pharmacy billing records, but they were continuing to receive other medical care. The study included 627 natal females and 325 natal males, with an average age of 19 years. The study found that over a 4-year period, about 1/5 of natal males and 1/3 of females stopped taking their cross-sex hormones. It was noted that 58% of patients had their first appointment for transgender-related care during the last 22 months of the study, so a more modern cohort of patients had a shorter follow-up time. This slide presents a study which looks at desistance rates for people on cross-sex hormones. It is an American study published in 2022 which looked at medical and pharmacy records between 2009 to 2018 from the US military healthcare system. They looked at the children and spouses of active, retired, or deceased military members who identified as trans. To be eligible for the study, the subjects had to have had at least 2 medical appointments on different days where a transgender-related diagnosis was given, and they had to have filled a prescription for a cross-sex hormone within 90 days of the appointment where they received the diagnosis. The subjects had to have filled at least 2 prescriptions for cross-sex hormones. The study looked at for people who had then had a greater than 90-day break from cross-sex hormones, according to the pharmacy billing records, and were continuing to receive other medical care. The study included 627 natal females and 325 natal males, with an average age of 19. The study found that over a 4-year period, about 1/5 of natal males and 1/3 of females stopped taking their cross-sex hormones. It was noted that 58% of patients had had their first appointment for transgender-related care during the last 22 months of the study, so a more modern cohort of patients had a shorter follow-up time. This slide is about the suicide rate among children and adolescents with gender dysphoria. Proponents of the affirmation model will frighten parents into affirming their child by making claims of high suicide rates, especially amongst children who are not affirmed. The suicide rate from the largest gender clinic in the world, the Tavistock's Gender Identity Development Service in the UK, was 13 per 100,000 children per year. It is understood that while the service was operational, 2 children on the waiting list died by suicide, and 2 children receiving treatment from the service died by suicide. The suicide rate amongst 10 to 19-year-olds in the general population is estimated to be 4 per 100,000 per children per year, but it is noted that there are large variations according to sex, age, country or residence. It is likely that the Gender Identity Development Service's suicide rate is in line with the suicide rate of children attending child and adolescent mental health services generally. This is understandable given the high level of mental health comorbidity found in children attending gender clinics these days. A linkage study from Norway looked at the Norwegian Cause of Death Registry and the Norwegian Patient Registry between 2008 and 2018. Young people in contact with the Child and Adolescent Mental Health Service within the year before their death by suicide were included in the study, which was 73 children. The study found a suicide rate of 22.6 per 100,000 children per year for females and 10.3 per 100,000 per year for males. So once again it appears that the suicide rate for children with gender dysphoria is similar to other children attending child and adolescent mental health services. Just a comment here about the Tavistock's Gender Identity Development Service. The service was heavily criticised for using a 4 to 6 session assessment model, which was later reduced to 3 to 6 sessions before children were referred for medication treatments. This number of sessions was regarded as inadequate to meaningfully explore the complex individual and family issues driving gender dysphoria. However, in Australia, the gender clinics will refer children to the paediatric endocrinologist to be prescribed puberty blockers in fewer sessions. I've seen children referred for puberty blockers after 2 sessions with a gender clinic social worker. Here is Michelle Telfer talking about the number of sessions they provide at the Royal Children's Hospital in Melbourne Gender Service.
So around that age, around that peripubertal age, they are allocated a mental health clinician who they see initially for 3 or 4 sessions, and then a paediatrician joins them for the 4th session, where we talk about medical options depending on where things.
In 2020, the UK National Institute for Health and Care Excellence undertook 2 systematic reviews of the evidence for the use of puberty blockers and cross-sex hormones as treatments for gender dysphoric patients under 18 years of age. The reviews were published in March 2021. The NICE review of puberty blockers had as its major finding that puberty blockers lead to little or no change in gender dysphoria, mental health, body image, and psychosocial functioning. In the few studies that did report change, the results could be attributable to bias or chance, or were deemed unreliable. The landmark Dutch studies were considered at high risk of bias and of poor quality overall. The reviewers suggested that findings of no change may in practice be clinically significant, in view of the possibility that the study subjects' distress might otherwise have increased. The researchers cautioned that all studies evaluated had results of very low certainty and were subject to bias and confounding. The NICE review of cross-sex hormones identified similar shortcomings in the quality of the evidence. The reviewers noted that a fundamental limitation of all the uncontrolled studies in this review is that any changes in scorelines from baseline to follow-up could be attributed to regression to the mean rather than the beneficial effect of hormone treatment. No study reported concomitant treatments in detail, meaning that it is unclear if positive changes were due to hormones or the other treatments participants may have received. The reviewers suggested that hormones may improve symptoms of gender dysphoria, mental health, and psychosocial functioning, but cautioned that potential benefits are of very low certainty and must be weighed against the largely unknown long-term safety profile of these treatments. This is a study regarding social transition out of the Tavistock's Gender Identity Development Service in the UK. It was published in 2023. The researchers noticed that there had been an increase in natal males being socially transitioned prior to attending their clinic. In 2012, only about 1/5 had socially transitioned, but by 2015, almost half of the natal males attending their clinic had already socially transitioned. This study looked at children presenting to the gender service between 2012 and 2016 and compared the mental health of those children who had already socially transitioned prior to attending the gender service to those who had not socially transitioned prior to attending. The children were aged between age 14 and 17 years, and there were 288 subjects included. The study found that there were no differences in mental health between children who had been socially transitioned and those that had not. They did find that the rate of depression was almost double in adolescent males who had not socially transitioned. However, this was considered to be due to age, as it was prepubescent males who tended to present to the clinic having already been socially transitioned, but adolescent males tended to present to the clinic not socially transitioned. it is well known that adolescents have a higher rate of depression than prepubescent children. This is a study from America published in 2021 looking at US military healthcare data between 2010 and 2018. The study looked at children, that is people aged under 18, with gender dysphoria and their siblings without gender dysphoria. The study looked at mental health diagnoses, number of healthcare visits per year, and medications prescribed for mental health. They looked at healthcare utilisation before and after the initiation of cross-sex hormones. The study included 3,754 trans-identifying children and 6,503 non-trans identifying siblings. The trans adolescents were 5.5 times more likely to have a mental health diagnosis, were using twice as much mental health care, and were prescribed twice as many medications compared to their siblings. Trans adolescents were over 7 times more likely to have been diagnosed with suicidal ideation or self-harm, 6 times more likely to have a mood and depressive disorder, and over 5 times as likely to have a psychotic disorder. The subjects were tracked for a mean of 7 years or so, and for 1.5 years after receiving gender-affirming medications. Among the 963 trans youth prescribed gender-affirming medications during the study period, the number of mental health care visits per year did not significantly change, and psychotropic medication use increased from a mean of 120 days per year to a mean of 212 days per year following the initiation of gender-affirming medications. This is a study that is often used by advocates of the affirmation model to suggest that gender-affirming care assists young people in their mental health. It was published in 2022. The study was a prospective study of 104 trans and non-binary youth aged between 13 and 20 who received puberty blockers, menstrual suppression and cross-sex hormones. The study found that these treatments were associated with a 60% lower odds of moderate or severe depression and 73% lower odds of suicidality over a 12-month period. The study started with 104 subjects but had only 65 subjects who completed the measures at the 12-month mark, which is a 37% loss of subjects over the course of 1 year, and we don't know about the mental health of those subjects that were lost. There are complicated statistics used in this study which make it hard to know whether the results are valid. It appears that the study's claim of improvement in mental health was derived from comparing the mental health of those subjects who received the affirming care compared to those that did not, which was 7 subjects by the end of the study. It's not explained why these 7 children did not receive medication treatment. It is possible that there were differences in the baseline level of mental health between the 2 groups that were compared. The time frame of 12 months is also a very short follow-up period. In summary, between 60 to 90% of children with gender dysphoria become comfortable with their own body by the time they reach adulthood. There is no evidence that children with gender dysphoria in Tanner's stage 2, that is age 10 to 12, are more likely to persist in their gender dysphoria. It is the whole course of puberty that can heal gender dysphoria through the formation of friendships, the sexual awakening, a broadening of activities, falling in love, and experiences of physical intimacy. There is no way of knowing which children will persist or desist. Social transition and puberty blockers prevent children from recovering from gender dysphoria. Claims of a 1% regret rate are not applicable to children and adolescents receiving puberty blockers and hormones. The suicide rate for children and adolescents with gender dysphoria appears to be in line with the suicide rate of children attending child and adolescent mental health services. This is expected given the high level of mental health and developmental comorbidity amongst these children. The evidence underpinning the affirmation model is of very low quality and does not provide convincing evidence of psychosocial gains to justify the harms. Thanks for listening. We've reached the end of the presentation.